Okay, 56 years old patient
Okay, go
underwent
ahead.
sigmoid colectomy. On the post-operative day 2, patient was found tachycardic along with shortness of breath and fever. ABG was done, and which was pH 7.54, PO2 of 5 kilopascal, partial pressure of carbon dioxide 6 kilopascal, and bicarbonate of 26. Yes,
So,
sir.
what is the differential diagnosis based on this scenario?
Okay, uh, atelectasis, pulmonary embolism, pneumonia, ARDS.
Okay. Uh, and abdominal sepsis. So, why you suspect pulmonary embolism in this patient?
Yes, sir. As the patient has recently undergone a major surgery and is only a post-operative day 2, and also he has signs of tachycardia and shortness of breath, and and also his AVG tells that there is a respiratory alkalosis which points toward pulmonary embolism.
So, the patient is post operative, and also there will be a prolonged immobility and increased risk of DVT due to virtue triad.
Yes.
All right. So, now tell me, can you
Mm,
interpret the arterial blood gas level here?
okay. Yes, sir. The patient is having respiratory alkalosis and hypoxemia, so type 1 respiratory failure.
Okay. Can you read the chest x ray here?
Yes, sir. It is inadequate, but the chest X-ray in right is normal.
Okay.
In left, there is a mild
Very good.
cardiomegaly.
Very good. Okay. Just tell him the chest x ray is normal. Okay. Now tell me, what is the ECG finding of pulmonary embolism?
So there will be sinus tachycardia, and there will be S wave in first lead, and Q and T wave in third lead, limb
Okay.
lead, and
Now
also
tell
there will be
me,
sign of
yeah, you are right. You are
uh,
completely right. Tell me about the investigation you will perform for this patient.
for this patient, the specific investigation I'd like to perform would be the CT pulmonary angiography, and also ventilation perfusion scan.
What else? You will go
So
for.
in blood, I would also like to do D dimer test.
Yeah, you will go for ECG, chest X-ray is already done. So go for arterial blood
Yes.
gas level, ventilation perfusion scan, CTPA. You mentioned and echocardiography. Now, if the
Echo.
CTPA, okay, if the CT is not available, what investigation you will do?
Yes, sir. We will do a simple angiography only.
Ventilation perfusion scan. Okay,
VQ scan.
yeah, the VQ scan. Okay, and if like you can also mention about the angiography, what you mentioned. Okay, very good. If the
Okay.
CTPA is not available, you can go for angiography and you can go for ventilation perfusion scan. Remember this.
Ventilation
Now,
perfusion scan.
what are the like if you perform the CTPA for this patient, what will be the
Yes, sir.
finding?
Okay, so in CT scan, there will be a filling defect in pulmonary vasculature, as most commonly a sidal embolus in pulmonary vasculature.
Okay. What are the causes of pulmonary embolism?
Okay, so most commonly it is caused from the dislodgement of thrombus in the peripheral vascular area, like DVT, deep venous thrombosis in deep veins of the
Okay.
calf, and also in sepsis in DIC, and also in long bone fracture there might be pulmonary embolism with fat or air.
Also in infective endocarditis, okay, IV drug abusers, amniotic fluid embolism,
Individually.
correct, and atrial fibrillation,
Yes, sir.
correct. So these are all the causes of pulmonary embolism. They will ask you, remember this, in history or in
Yes, sir.
ACCA. Now, tell me about the management of this patient.
Okay, so this patient, I would like to manage the patient with care of critically ill surgical patient protocol following ABCD approach. As the patient is hypoxic, I would like to um, administer high flow of oxygen. Mm. And if the patient is first unstable, then I'd like to do a tissue plasminogen activator therapy, or if the embolus is diagnosed as a massive in CT angiography, then I would first do the embolectomy, and for that we need a proper setup with cardiac surgeon and proper cardio pulmonary bypass facility. And if the patient is stable for now, then I'd like to start the patient with anticoagulant therapy. And if the patient was having this problem recurrently in past, then I'd like to consider about the IVC filter.
You mentioned that I'll manage this patient according to the care of critical surgical patient protocol. If the patient is
Yes.
hemodynamically stable, what you will do?
I'll just give patient anticoagulation therapy and monitor the cardiac index.
Very good. Okay. Started
And
like if
also,
the patient is
yes,
hemodynamically stable, I will go for anticoagulation therapy. If there is some contraindication for the anticoagulation, then I'll go for IVC filter. If the patient is hemodynamically unstable, then I'll go for the tissue plasminogen activator. But if the patient is having massive pulmonary embolism, then I'll go for pulmonary embolectomy. For that, we need a cardiac surgeon, cardiac facilities like cardiopulmonary bypass machine and cardiac center. Excellent. Okay, just mention about this hemodynamic stable
yes,
patient. How will you check the hemodynamic stability of the patient? By cardiac index. Remember, okay? All right. What
cardiac
is the
index.
pathophysiology
Yes,
of
sir.
the pulmonary embolism?
Okay, okay, so the blood, which is due to stasis and due to Borchers strat, there will be from formation of thrombus in deep veins, and it travels to the popliteal veins, then external iliac veins, common iliac veins, IVC, inferior vena cava, and right atrium, right ventricle, and then pulmonary vasculature. It blocks the pulmonary arteries and leading to uh, pulmonary embolism. And the signs will be the reflex tachycardia due to the uh, decrease in tissue perfusion
Okay.
of lungs, and
Okay.
is
Okay. The pathophysiology of pulmonary embolism,
yes,
remember, you have to mention about the right heart failure. It's very important. Dislodgement of the clot from the lower limb and it goes to the pulmonary artery and causes the pulmonary artery obstruction. Increase in pulmonary artery pressure, this will lead to right heart failure. Finished. Okay.
right.